It's my pleasure to present a new technique for the protection of patients who undergo segmental tracheal resection, known as the Laryngosternopexy. As the title suggests, it is a method for protecting that anastomosis from distracting forces of neck extension. Tracheal resection, as you all know, is the gold standard for the treatment of tracheal stenosis and symptomatic malacia that may be congenital or acquired, usually due to intubation or tracheostomy-related airway trauma. The process can involve the removal of a very large amount of the airway. In fact, over half of the airway can be removed with what are considered to be local releasing techniques, that is, avoiding the need for sternotomy and the release of the pulmonary ligament. However, even with the releasing techniques, a tremendous amount of suture line tension can be encountered, which would potentially harm the patient's recovery by distracting the airway anastomosis elements and producing a leakage of air and possibly secretions into the deep neck and mediastinum. So while these factors might produce a lot of suture line tension, I think it's fair to say that they can also produce a lot of post-op surgeon tension, because you're not certain whether or not the suture line will hold. The risks of the procedure are many, and certainly the worst and most life-threatening of these, at least in the early phases, is the dehiscence of the suture line. The Grillo stitch, as it was known in my training, is a traction suture invented by Professor Hermes Grillo, a physician, cardiothoracic surgeon at Massachusetts General Hospital, who invented it. It is a chin-to-chest pexy suture that is intended to prevent the inadvertent extension of the neck and undue strain of the suture line. It is considered to be a safety measure and is commonly used both by surgeons trained by Dr. Grillo and those who are aware of his techniques. He believes that you can get an additional 2+ centimeters of resected airway by using this technique, which keeps the larynx as low as possible relative to the chest, and thereby prevents undue suture line tension. Depicted in an article authored by otolaryngologists who term it in this case as the guardian stitch, but it is essentially the Grillo stitch. It involves getting deep bites of the sternal skin and possibly even the periostomy of the sternum, although I'm not sure how exactly you'd get that reliably connected, and then through the chin, possibly through the periosteum of the bone there, to tie it together and prevent the patient from distracting his head backwards. The few times that I've performed this suture, I've actually placed a second throw through the chest and chin in the form of a pulley, as depicted to the right, so that you would be dissipating the force necessary to keep the chin forward across a greater surface area, thus decreasing the force per unit area necessary to provide this safety. Because of the fact that I have been very uninclined to performing this portion of the technique, and many others who do this operation have developed a myriad of ways to avoid the use of the Grillo stitch. Certainly it's possible that if you're doing a very short resection, you may not need it. You may mobilize the larynx and trachea as much as possible using a variety of releasing techniques of the larynx, for example, such as the suprahyoid release, the inferior constrictor release, and extensive release of the distal airway from the thorax. You may keep the patient's head flexed forward at all times. It's hard to do. The patient can go to sleep and their head rolls off the pillows and they become extended. And then there's also the possibility of putting a C-collar on the patients, which tend to hold the neck in a neutral position rather than a flexed position. And perhaps really fervent prayer is in order. I'm sure that there has been many an airway surgeon who has relied on this. As a result, I developed the Laryngosternopexy suture to enable the same degree, if not greater, security. I developed it first while I was a faculty at the University of Maryland, and then later perfected it at the University of Alabama, Birmingham, where I am now. It is a traction suture attaching the larynx to the sternum at the sternoclavicular ligament. I use a pulley concept just as I described, developing it at the chin to chest side. It is remarkably well tolerated and is not associated with any particular